thank you all for being here. It's really fantastic to be here and speaking in front of people again. Okay, so we have a clinical microbiology fellowship at UNMC, and when they go out and look for jobs, one of the first questions that they ask me is, when I go, what kinds of things do I need to look for in the interview? And for me, I think the most important thing for a microbiology director is to fully understand that these particular relationships, microbiology and infectious disease pharmacy, stewardship, hospital epidemiology, public health, all of those particular relationships are so important for your success that when you go, you really need to make that decision whether you're going to be able to work with these particular people, because the impact that your laboratory has on patient care is built upon the relationships that you build with these particular entities. And that's because you go and work with these people, make decisions together, and the trust that you have together is built upon those working relationships. So it's really important for a microbiology laboratory director to not be in a vacuum and working in the lab. They really need to be out and working with multiple teams within the hospital. So what I'm going to do today is, we have a fairly brief period of time here before you have your breakout session. So I thought I'd just talk about 3 quick stories about how we've been successful in working with stewardship. And so the first one is linked to our blood culture testing and how we actually get those data out to providers, and most importantly, appropriate antibiotic utilization based upon those data. The second is appropriate beta-lactam utilization. So I'm going to talk briefly about extended spectrum beta-lactamases and carbapentamases. And if anybody wants to get in the nitty-gritty of all that stuff, let me know. I'm happy to talk about it afterwards. And then the third thing is talking about molecular testing. And we have, in the past couple of years, implemented an ammonia panel, and how that ammonia panel was actually put into the hospital specifically for its stewardship purpose. Okay, so susceptibility testing. All of you see susceptibility testing reports all the time. And one of the things that we have to do as a laboratory and as hospitals is we have to put an antibiogram together, right? An antibiogram data of all of the susceptibility testing data that you've generated for that particular year. And I think those are really important documents, but a lot of times at hospitals, those documents are generated, but they're not really utilized by the hospital staff, and they're kind of stuck in either the laboratory or the pharmacy. So here are some things that we've been able to do with the antibiogram data. Now, one thing about antibiogram data is that there's really a significant gap in antibiogram data across the country. It would be fantastic if we could link into some particular system so that if we had a really odd organism and we wanted to know the susceptibility of that organism across the country to multiple antibiotics, we could just go in and look at a fairly large number of organisms. But there really isn't anything like that, unfortunately. So we generally have to use our own local data for the decisions that we make. So this is the antibiogram that we have at UNMC Nebraska Medicine, and this was put together by Dr. Bergman and his group. And it's a really nice system where things are color-coded, appropriate appropriate empiric therapy are bolded. So I think it has an awful lot of data for the clinician and the nursing staff to look at appropriate antibiotic utilization for a particular organism. But I think that we can go further than just the individual clinician. How can we utilize these data in collaboration with microbiology? So here is a flow for what we use in the micro lab for, let's say, a blood culture, right? So we have a positive blood culture sent down to the lab, and it's put into our blood culture instrument. all of the blood culture instruments are continuously monitoring the blood to monitor for growth. Once it's positive, you get a light on the blood culture instrument. You go in and you pull the bottle and you do the gram stain, and you determine whether it's gram negative or gram positive. And this is typically when the laboratory calls a physician or the nursing staff to say that there's a positive blood culture. One of the great things that's happened probably within the past 7 years is that we can then take that blood and put it onto a PCR instrument, and there are multiple types of instruments that are available, and you can rapidly determine the species of that organism. So you put it on particular gram-positive or gram-negative kinds of panels, and you can figure out what the organism is, and it's really been impactful for our hospital. Including on that panel, there are particular genes of interest. There's MEK-A and VAN-A. Those of you who look at these know that MEK-A is the gene that confers resistance to oxacillin and staphylococci. VAN-A is the gene which confers resistance to vancomycin and enterococci, et cetera. Then there's CTXM, which is the most common ESBL that's present in the Enterobacteriales. And then there are the 5 carbapinamases that are present. We've never come across a carbapinamase in a blood culture before, but it's there. And then we have MCR1, which confers colistin resistance. So these are really low-hanging fruit associated with antimicrobial resistance. However, we know that we can utilize these particular genes to determine antimicrobial resistance. But why can't we use this approach for all types of resistance? Why can't we just put on the BioFire panel or the TREC panel, what have you, all these other markers to predict susceptibility? Well, it turns out that it's really hard to do that. For instance, we can detect CTXM as an ESBL, but all the other ESBLs that are present, they're called TIM1 or SHV1. Those without really sequencing the gene itself, you can't determine whether it's an ESBL or just an enzyme that confers resistance to ampicillin only. In another situation, let's say we have an Enterobacter cloacae, and one of the major decisions is we want to know whether it's resistant to third-generation cephalosporins or not. We can't tell by looking at the sequence whether it's going to be resistant to third-generation cephalosporins, because actually what's required is for us to look at the expression of those particular genes. Another example is like daptomycin resistance in Staph aureus. We really don't have a good feel if we sequence the organism whether it's going to be resistant or susceptible to daptomycin. So in many cases, we really can't determine susceptibility. So how do we do this? What's the best approach? And one of the things that we've done is we've been able to take and utilize our antibiogram data to document what are the most appropriate empiric therapy until the clinicians get the full susceptibility report. So on our stewardship website, and you could actually just use the little antibiogram card, but also on our stewardship website, there's a BCID document, blood culture identification document, which links the organisms that are detected. And then based upon our antimicrobial susceptibility data, the most appropriate empiric therapy for that particular organism. So you can get the BCID data, go to the document, figure out what's the most appropriate in therapy based upon our own local data, and then wait for the susceptibility data to de-escalate if required. So I think it's a really important thing for us to do, and I felt like I'm really proud of this particular process. Now, here is something that I think is the next step. So, as I just mentioned, it's going to be really difficult for us to use sequencing information and other kinds of things to document full susceptibility reports. So, how can we get those susceptibility data faster? So it turns out that there are a couple instruments on the market right now. One of them is called the Accelerate, and the other one is called Specific Diagnostics from bioMérieux. And they use kind of different approaches, but you can then take the BCID result and the blood from the blood bottle and inoculate a susceptibility testing instrument. and acquire data within 4 to 5 hours of a positive blood culture. So that's going to be a really neat thing to do. We're in the process of looking at this to see if it actually is appropriate and matches our own susceptibility testing data. But the key thing about these types of approaches is that if you're going to use rapid susceptibility testing, let's say you get your test on at 4 o'clock and the data are coming off at 9 p.m. Do you have stewardship available at that time to actually make those decisions for the clinicians to de-escalate or whatever you need to do? And so that's where I think once we get to that point where we have these particular types of diagnostic equipment in the laboratory, then can we also at the same time build the stewardship infrastructure so you can have 24/7 stewardship. So this is, I think, a really great example of how microbiology and the developments within microbiology really need to coordinate with stewardship to make it actually work appropriately. So here's another example, and I think this was the first one that we did. This was, I think Dr. Rupp and I did this back in 1999 or something like that. So, there are two particular enzymes that hydrolyze third-generation cephalosporins, such as cefotaxime, ceftriaxone, and ceftazidime. And I'm sure you all have heard of extended-spectrum beta-lactamases, and you probably heard of AMP-C enzymes. And it's this really complicated process where certain enterobacteriales produce AMP-C beta-lactamases on the chromosome and all that kind of stuff. But one of the things that we focus on are those particular organisms that we know do not produce AMP-C enzymes on their chromosome. And those are E. coli, Klebsiella pneumonia, Klebsiella oxytoca, Proteus mirabilis, Salmonella, and Shigella. So those organisms we know are kind of beta-lactamase free. They don't normally have any beta-lactamases present. So what we like to do in those organisms is we like to differentiate between those particular species that produce extended spectrum beta-lactamases versus those that produce AMP-C beta-lactamases. And the sole reason we do that is because if you have an organism that produces an AMP-C beta-lactamase, you can actually use cefepime. If the organism is producing an extended spectrum beta-lactamase, you can't use cefepime. So we have these reports that are sent out. If it's an organism that has an ESBL, we note that it's an ESBL. If it's an AMP-C enzyme, we note it's an AMP-C enzyme, and the reports are actually noted with that regard. So those that have an ESBL ESBLs are inhibited by clavulanate, and we know that because we can put it on the panel. They're generally cefoxtin susceptible. And the only reason we have cefoxtin on our panel is to determine whether the organism is an ESBL or an AMP-C enzyme. Generally, ESBLs are cefepime resistant, and if they're not, we switch it to resistant. And we also, even if they're piptazo susceptible based upon the resistance phenotype, we switch it to resistant. In contrast, AMP-C enzymes are clavulanate resistant. They're not inhibited by clavulanate. They're cefoxtin resistant. They're cefepime susceptible generally. And their piptazo is variable, and depending upon the type of enzyme, you get kind of a variable result. So anyway, we go through this process that again was generated by conversations with stewardship and infectious disease to be able to really confidently make these decisions. And what we've been able to do is we've been able to save cefepime in those particular instances for use for those organisms that are producing an AMP-C beta-lactamase. In a similar vein, we also like to use similar types of approaches to determine whether an organism is producing a carbapinamase. Carbapinamases are a really significant issue for obviously a lot of nursing homes as well as tertiary care centers. So we have a particular set of criteria that we use to determine whether an enterobacteriales may be producing a carbapinamase. And one of the interesting things and somewhat complicated thing is that we have to differentiate between those particular maybe resistant those organisms that are resistant to carbapenems that are not producing a carbapenemase versus those that are clearly producing a carbapenemase, because those particular organisms that are just resistant to carbapenems are sometimes called CRE versus those that are producing a carbapenemase as CPEs. The CPEs are much more serious for infection control because there's generally those genes are found on plasmids and can rapidly spread within a population. So it's really important for us to find those particular organisms that are producing carbapenemases. So it's important for infection control, but also one of the other important things is that we have to find out what particular carbapenemase is produced, because because that is linked to the type of therapy that the patient should get. So, for instance, if an organism, if the organism is producing KPC, you have multiple antibiotics that are maybe available, such as meropenem, vaborbactam, imipenem, relebactam, ceftazidime, avibactam. Those are all antibiotics that can inhibit KPC. However, if you have another one called OXA48, generally the only antibiotic available is ceftazidime, avibactam. If you're producing NDM, you have to take kind of a different approach with aztreonam plus maybe ceftaz-avi. So all of those particular clinical decisions are based upon us finding the particular carbapenemase that is present. So again, we had conversations with stewardship and infection control and hospital epidemiology. What kinds of things do we need to do as a laboratory when we come across these particular organisms? What kind of reports need to be given to the clinicians? And so a wide variety of different conversations that have led to this particular approach within our hospital. And the last little quick story that I wanted to mention is molecular testing. Now, in a lot of laboratories, there are clearly a lot of newer PCR tests that are available to detect a wide variety of different pathogens. For instance, there's the already mentioned blood culture PCR, BCID panel. There are panels to detect diarrheal pathogens, the GI panels, which are widely used and important for public health. There's a meningitis encephalitis panels, PCR, which are also very important to rapidly diagnose patients with meningitis encephalitis. There's almost all of the virology today there is based upon PCR results. There is no more culture anymore of viruses in most all laboratories. And one particular newer panel that we've implemented at UNMC or Nebraska Medicine is the pneumonia panel. And it was a really interesting opportunity for us to utilize this panel in a particular patient population and then determine what the impact of the use of that panel is within our hospital. So this is a panel which has a wide variety of viruses on it. It currently does not have SARS-CoV-2, which is really too bad, but it would be really important to have SARS-CoV-2 on there. It does have pretty much the same type of antimicrobial resistance genes associated that you found on the BCID panel. But it also has a wide variety of different bacteria that are present, and most of those bacteria are actually quantified. So you get a value of 10,000, they're called Ben values, 10,000, 100,000, greater than a million, or a million and greater than 10 million. So you have kind of a quantitative level of the organisms that are present, and that actually turns out to be very important. And then you also have some atypical organisms on there, Legionella, chlamydia, et cetera. So how did we use this in collaboration with stewardship? First of all, we made a decision not to utilize this for community-acquired pneumonia. So this panel is not used by ED physicians. This comes from recommendations where generally diagnostics are not required for community-acquired pneumonia. So we decided to primarily put this panel in our ICUs, and we've restricted the use of this panel to infectious disease, pulmonary, and a few other groups. And you know, when I was when we start to use this panel, I was really excited about the panel more as a diagnostic device, and I think it has been used in that way. We found, I counted the other day, we've had around 3,500 of these ordered since May of 2020, and 6 of them have been positive for Legionella. So I think in those particular cases, it was diagnostic, and probably those patients, they probably didn't know that the patients had Legionella, so that was pretty important in that case. But overall, I think that what we've been using this for is as a tool to de-escalate anti-pseudomonal and anti-staphylococcal therapy within the ICU. And I think that our physicians are becoming really comfortable with the fact that if they do a pneumonia panel, if a patient comes in with pneumonia into the ICU and they do not detect Staph aureus or Pseudomonas, they can de-escalate from that therapy. One of the other things that we do is with the pneumonia panel, we also require a culture, and that culture is actually a really important piece to interpret the pneumonia panel. Sometimes what you can detect Staph aureus or Haemophilus influenza in the pneumonia panel because it's a PCR test and it's really sensitive, but you can't actually find it in culture. And that happens frequently. And so we use the culture as kind of the tiebreaker on whether or not, a lot of these things may be important or more normal flora. But another important thing that I think change that we made, and this also came from stewardship and a paper that was published, is that if we don't find any Staph aureus or Pseudomonas in the culture, then we put a comment on that the culture is negative for Staph aureus and Pseudomonas aeruginosa. And you would think that if the culture doesn't say that there's Staph aureus or Pseudomonas, that would imply that there's no Staph aureus or Pseudomonas. But in actuality, it turns out that if you actually state that there's no Pseudomonas or no Staph aureus, there's actually documented action by the clinicians to potentially de-escalate therapy. So studies are currently being performed right now with stewardship and other groups to document the impact of this particular assay within our hospital, but I think it's been a really, again, another really good example of how we've collaborated and made decisions together to generate trust. And the last thing I wanted to mention is that in the future, what are other things that are coming up that I think that microbiology and stewardship can really collaborate on to make an impact? Now, microbiology is changing really fast, and I would say that in my career, I'm clearly going to be in the business of utilizing sequence data, having bioinformaticians in the laboratory, potentially having metabolomics based upon skin flora or gut flora. It's really interesting when you look at the microbiota of the skin or the mouth or the gut. It's not necessarily the organisms that are present that are important, but it's actually the jobs that those organisms that are being done. So you don't necessarily need to look at the organisms to see what organisms are present. You need to find out what particular metabolic niches are lost within that flora. So I think we're going to have to use a lot of metabolomics if we're going to go down that road. So I think those kinds of things are coming, and we need to figure out how to use those most appropriately. But they're going to be really expensive, and we have to figure out what particular patient populations we're going to use these tests on. And we're already coming across similar kinds of things. There are tests available that, for instance, you can send in some tube of blood, and if an infection is found anywhere in the body, it actually you can find floating microbial DNA in the blood, and you can sequence that. And you can potentially find the causative agent of an infection. It's called Carius testing. It's Carius company. So that's actually being done right now. There's places which do a whole genome sequencing from CSF or other sterile fluids to find organisms that may be present. And there's clearly targeted 16S sequencing. We're developing some of these technologies at our laboratory. But what patients should be tested here? What particular physicians should actually be ordering these tests? Should all these tests be coming through infectious disease or stewardship. So these are challenges that I think that we have ahead. And again, I'm really, really thankful to have such a fantastic stewardship group at UNMC so we can make these decisions together. So with that, I think I'll, if you guys have any questions about resistance or how we report things or whatever, just let me know. Yeah. Yeah. You're talking about the Carious testing? Yeah. Yeah, so Carious testing is available for anybody. It's a company, and that's their approach. You send a tube of blood to them, and it's not like it's at a particular reference laboratory. So it's available for anybody, but it is very expensive. It's not something that you would want to do on a whim. So I think the test for the laboratory is about $2,500, and you know how things are marked up for the patient. So it would be a really significant decision before you would make that decision.
Great talk. Not every lab detects ESBL or reports ESBL phenotype. Could you talk just a little bit about how to think about that when, say, the lab that you're using doesn't report ESBLs?
Yeah, so that was interesting. So when I started my career, I don't know if any of you have ever looked at a CLSI manual before, but most laboratories follow for susceptibility testing. When you get an MIC result, to interpret that result, you go to this particular document called the CLSI. And for a long time, if you detected an ESBL, and the way you detected it was you had resistance to third-generation cephalosporins, and then that resistance went away when you added clavulanate to that antibiotic. And the organism was cefoxytin susceptible. So there are a wide variety of ways that you confirmed an organism was an ESBL. And when that happened, then the CLSI recommended that you would switch all of the third-generation cephalosporins, as well as cefepime when it came out, and piptazo to resistant. And that's because what happens is that these particular enzymes evolve. So a lot of these enzymes came from original enzymes which didn't hydrolyze third-generation cephalosporins, and so the mutations within those genes were selected and evolved within a particular third-generation cephalosporin. So you may find that if you have a particular ESBL, it'll be resistant to ceftazidime, but intermediate to cefotaxime and susceptible to ceftriaxone. And yet, you wouldn't want to use ceftriaxone in that patient because clinically it's resistant. So you would have to switch that to you'd have to switch the ceftriaxone to resistant. So you'd have to find the ESBL. You had to detect it. Well, I can't remember what year it was, maybe around 2010. They changed their recommendations such that finding an ESBL was not necessarily as important, and there were feelings within certain clinician groups that you could go ahead and treat based upon the susceptibility report. So many laboratories stopped reporting ESBLs and just sent out the report. We made a decision not to do that, and we've always switched our third-generation cephalosporins. But I think since, I think one of the most critical papers that came out was the Marino trial, where documented with ESBLs that piptazo was inferior to meropenem in blood cultures. I think it's really important, in my opinion, to at least with piptazo, if you have an ESBL, to not report it as susceptible if it is. And so I think those are maybe conversations that you might need to have with your microbiology lab to see exactly how they are dealing with that. Are they detecting ESBLs, and when they do detect it, what do they do with it? I think that's an important conversation, and you can make a decision as a hospital group or what have you on how to do that, but it's important for you to know exactly how it's being done.
All right, thank you, Dr. Fay. Very, very interesting. All right, we're going to take a break, 20 minutes. Long-term care facility track will be in here. The acute care facility track, ambulatory, will be right next door. And so have a few minutes. I think there's some snacks back there I heard, some water. So please, in 20 minutes, so that's at 2 o'clock, 15 minutes, sorry, at 2 o'clock, next door for acute care, here for long-term. Thank you all for coming.